I like doing these lectures virtually when we can because we get the opportunity to do these as polls. You don't have to play along if you don't want to, but there's something about picking an answer, identifying that answer, and kind of standing on it that can either one, help create a lot of confidence, or two, decrease some of the nervousness of being on a test and seeing the same type of question. If you don't really give you guys a couple minutes to read, throw an answer in the poll if you want to. All right, we'll close the poll. You can kind of see there. Something tempted everybody, right? And so let's kind of go over this. Over the past 2 days, 14 patients come to an urgent care, similar symptoms. The staff is concerned for a bio attack. This is a good example of, do we even really need the vignette to answer this question? Not really, right? You can just read the question and say, hey, which of the following is most consistent with a smallpox outbreak? So being familiar with smallpox, the signs, symptoms, and physical exam findings can be very helpful. And in this case, delta is the correct answer. So the pox lesions in a smallpox outbreak tend to be at the same stage in development. A rash that spares the palms and soles. In this case, does smallpox hit the palms and soles? It does. It's one of the few dermatological manifestations of the virus that hits the palms and soles. Pox in a centripetal fashion. Centripetal means more the center of the body, not the peripheral of the body. Which one would be more familiar with Bravo there? Remember, it's not one that we studied. We just had a chart on it. And then smallpox does tend to have a fever. And asynchronous is mean they're different stages of development. So when we did our smallpox lecture, we kind of threw this stage up. Variola is the smallpox, right? And there is a fever. The lesions tend to be more centrifugal. They are synchronous in distribution, whereas varicella or the chickenpox, minimal, if any, virus or fever in the prodrome, more centripetal or center of the body, and they can be asynchronous, meaning you have pox at different levels of development. And so that's an example of how we can kind of start to differentiate smallpox versus chickenpox. Good job. All right, we can talk about this one here. Published results. Again, one answer teased a lot, or all answers teased everybody at least a little bit. And overall, the correct answer was selected B, intravenous triple antibiotic therapy. All right, so let's talk about this first. This is an example of second or third order question, depending on how you look at it. But we got to first know what's being described here. So take in the description. What condition do we have at play? If we don't know the condition, if we're not confident in what the condition is that we're treating, it'd be very difficult for us to answer the question. Anybody want to take a stab at it? What are we treating? See a lot of people typing in. I expect you all get it. This is gastrointestinal anthrax. And so first of all, we know that anthrax, there's 3 types of anthrax. You guys remember those 3 types? The cutaneous, intestinal, and inhalation. And in this case, we're describing significant GI symptoms. And this person is hurting bad. If you kind of read this out here, this person's hurting bad, right? It even says he's in acute distress, pretty high fever, significant tenderness. Patient even reports acute abdominal pain, right? So we know we have this. Now, I will tell you, in my opinion, this specific vignette may not give everything you need to know about it to go ahead and call this intestinal anthrax. However, contextually speaking, out of the biological warfare lecture, this is really the only one that fits. And so I'll make sure I do a good QC job on a test in a couple days to make sure there's nothing left, but it's pretty good for what we're working on today. So we got that. So then we got to know, all right, what do these people mean? So is this bacterial or is this viral? And Joseph already said it, this is bacterial. So some type of antiviral won't work. We do need an antibiotic. And is this individual somebody that seems stable enough to treat on an outpatient basis? It does not. This person is a very toxic setting, very acute. So they need some type of extra support. So in this case, IV triple antibiotic is appropriate for acute intestinal anthrax. Now, supportive therapy and inpatient care, is that helpful in this individual? Absolutely. If we get them into the inpatient setting of the hospital, give them IV fluids, we can help them. But in this case, this person doesn't need just 1 but 3 antibiotics to cover the bacteria. Anybody remember the name of the bacteria? What's the causative pathogen in anthrax? Charlie is oral Cipro and Doxy. Does Cipro and Doxy play a role in intestinal anthrax? Does it play a role in intestinal anthrax? That's the question. Perfectly right. Bacillus anthracis is the causative pathogen. I expect you to do that. I appreciate you for stepping up to the plate quite a lot. Does oral Cipro and Doxy play a role in intestinal anthrax? It does, but what role does it play? That's the differentiating factor between Charlie being incorrect versus correct. In this case, do we have a patient who is stable enough to take oral antibiotics? We do not. So in this case, the patient is labile enough or in acute distress enough that we need to do intravenous antibiotics. When they are recovered to a place where they are safe and stable to go outpatient, we will transition over to oral antibiotics. And Cipro and Doxy have a role for it at that point. How about Delta? Are those even antibiotics? Delta is Biktarvy. What condition does Biktarvy treat? What is that one indicated to treat? HIV, exactly. And what about tecovirimat and brinzodifovir? What do those treat? So first of all, are they antivirals or antibiotics? They're antibiotics. So they would treat a virus, and we don't have a virus, and so they have a better player in the small ones. And here is kind of where we would get some information out of our slides to help answer this question. We got our signs and symptoms of intestinal anthrax, our culture and gram stain results, and then our treatment of it is a triple antibiotic therapy. We can transition to oral therapy when they are more stable.
Because I can understand that you guys can hear me.
All right. Overall, really great job. The correct answer is echo. Now, what is the condition that this person has? What is the condition that this person has? The condition is Bravo, bubonic plague. Absolutely. This is one of those kind of like test taking skill set reminders. We are not asking in this skill set or this test, what is the condition? It's very specifically to an exam finding. And it's a pretty classic exam finding for bubonic plague. And you'll get tested. You'll see that on all kinds of tests throughout your career. And so that's just kind of, so is it in the correct area of the world? Yep, kind of that southwest corner of the United States. What's the vector for bubonic plague? Anybody remember what the vector for bubonic plague is? So Yersinia pestis is the pathogen. The vector would be the thing that brings it to the person. Fleas. Somebody I think said rodent urine, and there is one that we talked about that does have to do with rodent urine and feces, but it's not Yersinia. Anybody remember what the rodent urine feces is? Usually deer mice. Antivirus. Yep. Easy to get these mixed up, right? And so that's the point of us kind of practicing these so we can see some of the nuances and differences. And that bubo is a gigantic swollen lymph node. Lots of times in inguinal canal because fleas commonly will attack and bite the lower extremities. Good job. And Yersinia pestis, somebody put that, that's the pathogen. So good job. And there's some information on how we would get that derived from our students. My goal with a lot of these is so that you guys can start to kind of see how the information that we will be tested on is attainable through the slide decks and the presentations, but it'll hopefully kind of lean into the fact that we'll need a little bit more than just memorizing the slides. You'll have to put some functionality to the information, but get some good practice at it here. I think we have one more. Yep, one more. All right, we'll talk about this for a second. So, staying in the biowarfare realm, what is the condition that we are concerned most for? What is the condition that we are most concerned for based on the description here? Inhaled anthrax. Yep. So anthrax, several different types. This time it's an inhaled anthrax. And the question specifically, most likely that we're going to find kind of on that workup, hemoconcentration. There is a condition that we saw that we might run into hemoconcentration during our lab testing, and that's a pretty ominous finding. What condition might we find hemoconcentration in? What infectious disease that we talked about? What was the hemoconcentration? Remember we talked about that it was more of a lack of fluid within the bloodstream, right? It's artificially elevated. That would be antivirus. What would we use the Western blot for? What would we use the Western blot for? What condition does the Western blot come into play? HIV, and specifically it's the confirmatory test. Yep. Brawny edema, that's a physical exam finding. What condition would we potentially see that big, beefy, red, sharply demarcated brawny edema? Anthrax. All right, Paul, good job. What is the classic kind of history for cutaneous anthrax? What do we typically tease out in the history for somebody who's got that big, hefty, brawny edema? Not always, but very common. So Eshkar is another physical exam finding. That's going to be in the center of it, right? And so kind of the history item that we're relating to is a lot of times these are in the spores are in the hides of cattle or wildlife or something like that. And so you might tease out that somebody was processing or moving dead animals or something like that. And they had some type of contact with that infested hide, and they're broken with their skin, they got cutaneous. Echo, violaceous skin lesions. What's the name that thing is describing right there? What is the name of that super classic physical exam finding? Violaceous skin lesions. Kaposi sarcoma. And what do we see Kaposi sarcoma in? That's kind of a classic setting that we see Kaposi sarcoma. Yeah. So it's an HIV individual who has crossed over a threshold into that acquired immunodeficiency syndrome realm. So Kaposi sarcoma might be what they call those AIDS-defining illnesses. Yep, and the whitened mediastinum is what we'll see on a chest X-ray. Big old bright white, whiter than it should be. And what is filling up that mediastinal cavity? Just pooling into all of that potential space between the esophagus, the heart, trachea, lymph nodes. What is it that's causing that mediastinum to be dilated? Usually hemorrhage. It's usually a hemorrhagic white. Okay. Those are some practice questions for us. Let's get into the meat and potatoes of today. And here's an example where we get that from our slides. You guys did a good job. Yeah, we're doing a really good job. All right, viral hepatitis. There are lots of things that can cause a hepatitis. We're going to stick via our course of infectious disease into a couple of the viral settings here. Some topics we'll discuss: hepatitis A and E. These are fecal oral route viral hepatitis, and then their B, C, D are all serum related. And then you'll see there used to be this thing called hepatitis G. It's no longer a thing, and they found out it doesn't actually affect the hepatitis. Not positive why it's stayed in our curriculum. We will focus on hepatitis A and E, that fecal oral route, and then the serum hepatitis B, C, and D. And the schematic you see on the right-hand side of the slide here is a drawing rendering of hepatitis B virus. We'll talk more about that. All right, kind of a very simplified overview. Hepatitis just means an inflamed liver. There's lots of things that can cause an inflamed liver, and we're talking about a viral infectious etiology of an inflamed liver. There is an acute stage, there's an advanced disease, there's fulminant hepatitis and chronic hepatitis. So kind of four different ways that you can kind of think of it. And you can put some of these together, right? You can have an acute fulminant disease, you can have a chronic and advanced disease. So just kind of in the acute stage, usually you're going to have kind of viral syndromes, people kind of describing malaise, nausea and vomiting, some diarrhea, they might have a fever, and that liver lives in the right upper quadrants. There might be some pain and swelling there. What does anorexia mean? What does that medical terminology mean? Not talking about the psychiatric condition. So Rachel, excellent job. I heard it described once, and it's more than not having an appetite, it's refusal
You're
to
gonna have to
eat.
type.
And while you're not wrong by saying having no appetite, because having no appetite means you don't want to eat, usually when we say it in medicine, these individuals have something going on that they are refusing to eat. Somebody with an appendicitis might report anorexia. And there's this kind of like internal knowledge that it's going to hurt if we eat something, and so they just completely refuse to eat. God bless it, one of my sons developed an acute appendicitis in the middle of a PCS. He almost passed away from it. And one of the things that I look backwards now and I remember is that he absolutely refused to eat. Like he was trying to eat to make mom and dad happy because we kept asking him to eat, hoping he'd get better kind of on his own before we realized it was an appendicitis. Then all of a sudden his appendix ruptured. He jumped up off the table and he was like, "Hey, can we go get some Panda Express?" So he was hungry all along, just inside he didn't want to eat. So yep, these individuals, they will have a complete refusal to eat. When it gets a little bit more advanced, we might get this really darkened urine. They call it Coca-Cola urine. It's an incredibly dark urine. And that is from bilirubin that is no longer properly processed and made by the liver. It now seeps into the blood gets filtered by the kidneys, and that bilirubin then goes into the urine, making it significantly darker than it typically would. Another kind of, let's see if it's on this next slide before I start talking about it. It doesn't. Another kind of thing, there's another slide, that people might complain about. This is kind of one of those weird symptoms associated with hepatitis that you'll see in a lot of questions, is pale stools, pale poop. And what ends up happening is that bilirubin, that is part of bile, it gets broken down, and instead of being processed correctly and going to the gastrointestinal tract to help break down different particles, it just stays in the bloodstream. So all that bilirubin that would previously be in the bile is now in the bloodstream, getting filtered out by the kidneys. It's going into the urine, making it darker, and it no longer is available to help break down food in the GI tract. It doesn't stay in the stool, which is part of the reason stool tends to have a darker color. So we can also get darkened urine and pale stool. Jaundice is a clinical exam finding. Anybody remember what jaundice is? If somebody says somebody's jaundice, means their skin has a yellowish color to it. And there's a specific word that describes yellowing of the sclera of the eyes or mucous membranes. Anybody remember what the yellowing of the sclera is? Icterus, yeah. So a lot of people might use the word icterus and jaundice kind of interchangeably. They're not completely interchangeable. They do both represent a yellowing of something that was previously not yellowed. But jaundice specifically is more related to the skin. Icterus is more related to the sclera of the eyes and the mucous membranes. All right, fulminant hepatic failure, meaning that the liver is wildly inflamed and it's just in terrible shape. You may get somebody with an encephalopathy. Excuse me. And then chronic hepatitis can lead to both cancer and cirrhosis. If that virus just continues to damage that liver over and over and over again, those cells just become scarred down and cirrhotic, can't do their job. And then cancer, of course, can present a very weakened liver like that. On the physical exam can vary a little bit depending on what is actually at play, which virus is going on, whether it's acute or chronic, whether it's fulminant or subacute. But in general, some people can report vomiting and again anorexia. They may have signs of dehydration. tachycardia, dry mucous membrane, it's loss of skin turgor, those kind of things. Icterus, we already talked about that. Icterus is that sclera, or the mucous membrane turning a little bit more yellow. Jaundice is a little bit more related to the skin. And then the rat, there could be some types of skin defects, and there could be some liver might be actually large and tender as well. That exam finding we talked about when we were doing the abdomen exam about there's no hepatosplenomegaly. In other words, the liver is not enlarged past what we typically consider a normal range, but it can be in any hepatitis. Here's a picture kind of representing some jaundice. You can see that skin looks like a highlighter's kind of been all over that skin. And then an example of icterus, that sclera has actually yellowed a little bit, you can see. In my medical career, I have not seen a ton of jaundice or icterus, but there is one that really stands out. There was a veteran who was a chronic alcoholic and just killing his liver, and eventually ended up with a cancer in the hepatobiliary tree. And I walked into the room and to evaluate him, and he was like glowing yellow. It was a wild, very memorable moment because I just couldn't believe how robust the finding of that jaundice and that icterus is. That bilirubin just can't process out like it needs to. It's dumped into the bloodstream, and then it goes and deposits itself wherever it can. So yeah, jaundice and icterus. All right, some labs and diagnostic tests that we can do. We can screen for the different known viruses that can cause the hepatitis. We can look in the urine for presence of bilirubin. We can do a liver enzyme panel. AST and ALT are the typical liver enzymes that we monitor. Amino aspirate transferase, amino, I forget the others. AST and ALT, we just hear them abbreviated like that a lot. Question, let's see if you guys kind of remember this. AST and ALT are both liver enzymes that can be elevated when hepatitis is applied, when the liver's inflamed. If AST is higher than ALT, what is very likely the cause of the hepatitis? If the AST is higher than the ALT, what is likely at play there? Anyone want to take a guess at it? You may not have learned this yet, and that's okay. Nope, not blood obstruction. Alcohol. If you have an alcoholic hepatitis, an alcohol-related hepatitis, a lot of times you'll see the AST significantly higher than the ALT. And like I explained to you guys, my brain is a little bit weird, right? It looks funny, and so I would always think the S in AST stands for a saucer, which is an old phrase, old school term for somebody who's an alcoholic. And so AST being elevated more than ALT could be a sign of alcoholic hepatitis. So when you get ALT that is higher than the AST, it's likely a non-alcoholic related item. So you need to think some type of cirrhosis, viral hepatitis, with cancer, autoimmune disease. All right, we want to check our PT or our prothrombin time. And the prothrombin is made by the liver. What does prothrombin help in? What function of the body do we see PT being a very big player in? Anybody happen to remember? See a bunch of you typing. I'm sure you're typing in all the right stuff. Coagulation channels, absolutely. So the PAT is extremely important in that coag cascade. So if we have a decrease in PT secondary to liver damage, what symptoms and or findings might we find in our patients? Maybe they bleed easy, bruise easy, they can't coagulate, stop bleeding appropriately. So if we do a coag panel and we see that PT is off, it could be a sign of liver damage as well. And then a BUN and serum creatinine, the blood urea nitrogen or nitro, be a sign of decreased renal function, and then it could be secondary to pulmonary hypertension. So did any one of those tests we just talked about tell us we have overt viral hepatitis? Nope, because except for I guess for the screening for the viruses specifically, but these are all lab findings that we can put in play to evaluate the condition of the liver and whether it's working properly or not, and the severity of it. Then that could take us down to our differential of what is causing the different things that cause liver inflammation. All right, some treatment options. These are disease specific, meaning depending on which of the viral hepatitis is at play, we might change our treatment plan. Overall, supportive therapy, symptomatic therapy works for most patients. A lot of these they will resolve on their own, specifically A&E. All right, we just talked about A&E a little bit ago. How do we kind of classify hepatitis A and E? I hate the game. I hate that game. What am I thinking right now? Is it fecal oral or is it serum related? It's up for hepatitis A and E, fecal oral or is it serum related? It's fecal oral. That's exactly right. And these tend to be self-limiting. The patients hurt, right? They're not feeling well, but it tends to be self-limiting. Hepatitis B and C, they can resolve, but they also may need antivirals with it. And of course, it's a case-by-case basis based on how the patient is. Some things that can be on the differential, if you have somebody with a hepatitis, alcoholic hepatitis is always on the differential. Medication can cause it, autoimmune disease can cause it, hepatocellular cancer can cause it, pancreatic cancer. There are two things here, two things that are not mentioned here that I would recommend you consider if you have an acute inflamed liver. And one is cholecystitis, gallbladder disease. If it's inflamed, can cause a elevated AST, ALT. And then non-alcoholic fatty liver disease. While we call it non-alcoholic fatty liver disease, a lot of times it's abbreviated NASH, non-alcoholic steatohepatitis. So those are things that could be at play as well with these individuals that have an inflamed liver. All right, we saw this already. Fecal oral is our A and E. Serum is B, C, and D, and G doesn't exist anymore. The thing exists, it's just not a hepatitis. All right, let's talk about hepatitis A. Endemic in underdeveloped countries. It's fecal oral. You'll see them in these places where they are either higher risk people, close contact, poor hygiene, etc. Here are some areas that hepatitis A is found. Types of transmission. These two things, I guess three things, number 2, 3, and 4 here. Foodborne, infected food handlers, and raw shellfish. For whatever reason, people love to test on hepatitis A, and it's one of those three things. A lot of times people talk about somebody went traveling, they end up eating some raw shellfish or some food that wasn't handled properly because they had poor sanitation standards, etc. And then they have an acutely elevated AST, ALT. What is the condition? That fecal oral route they're talking about, it's not necessarily somebody's eating someone else's poo-poo. Usually it's related to poor hygiene, right? People are not washing their hands and their bodies as well as they should be. And then there's some cross-contamination of some of that hepatitis A virus. It is some fecal matter that gets microscopically transmitted to food that people eat. There can be some jaundice, and you see at the bottom the signs and symptoms. And it should be exactly what you expect from one, a viral infection, but as well as a virus that hits the liver, right? Something in the GI tract, nausea, anorexia, jaundice, vomiting, fever, abdominal pain. There it is, pale stools. That bilirubin is not in the bile like it needs to. It's going to the urine, making the urine darker and making the stool lighter. In diagnostic tests, IgM, or antibody against the hepatitis A virus. Do you guys remember IgM versus IgG at all? Probably studied in immunology, allergy or immunology. IgM, is it early stage or late stage? That's the big takeaway I want you to remember between IgM and IgG. Which one is early stage, IgM or IgG? Exactly. IgM is early stage. And so a lot of these hepatitis A, because they're self-limiting, we oftentimes won't even test them and get to the IgG and get there eventually. So if you get an IgM, somebody's in the acute stage, they're mounting an immune response. Treatment and or prevention, supportive therapy. We can give the vaccine, we can give immune globulin, but for the most part, if we have an otherwise healthy individual, it should be a self-limiting and should be cleared without any issue. All right, hepatitis A vaccine or virus immunization. There is a vaccine that's available. Potentially, if you have somebody go to do some type of activity that's a higher risk for it, they might get the vaccine. You can get it post-exposure as well. I'm sorry, immune globulin is post-exposure. All right, hepatitis E, still in that fecal-oral route of transmission. Again, common in undeveloped countries. And man, this looks different. It's all capitalized. Typically a very benign self-limiting case, except if a pregnant individual gets exposed to hepatitis E. That's a pretty good mortality rate. If you think 25% of pregnant individuals who get hepatitis E end up passing away, that's pretty significant. So hepatitis E, otherwise pretty tolerable, very similar presentation, still fecal oral, but it happens to be present in a pregnant individual, much significantly higher risk for hepatitis. Here's some areas that it's really commonly found in. Some lab tests, look, we're talking about IgM and IgG again. If we have hepatitis E virus antibodies, IgM antibodies, it's acute. If we pull out and we see that there's IgG, then they're recovered from it. All right, here we go with uncooked shellfish again, inappropriately handled fruits and vegetables. Think of, again, poor hand sanitation, stuff like that. Usually self-limited course, but hepatitis E, got to remember those pregnant ladies, pregnant individuals, a little bit higher risk. I shouldn't say little, that's pretty big higher risk. Hepatitis B. Hepatitis B gets a lot of attention based on the serology findings. I'm going to take a minute and talk about those. It's a DNA virus. It is not an RNA virus. Of the hepatitis viruses we're going to talk about, this is the only one that's a DNA virus, not an RNA virus. And it's incredibly infectious. It's very easy to become infected with hepatitis B. And usually it's through bloodborne pathogens. So blood exposure or sexual exposure tends to be the way that people get exposed to it. And it's all over the place. And chronic hepatitis B, if untreated, causes a lot of liver damage and obviously lends to cirrhosis and cancer if untreated as well. The onset is typically insidious. In fact, a lot of people won't get that robust viral response that we might expect. And so they may not even come and quote unquote get checked out for something early on. They may just kind of not feel good, get better, and then it's all done. Most of the time, if you have an acute hepatitis B infection, it is in an adult, and they tend to have pretty good recovery. The problem with hepatitis B is it has such chronic complications if it goes untreated and undermanaged. All right. We're going to talk a minute about the serology, or in other words, the immune lab findings related to hepatitis B. So the hepatitis B surface antigen is the first serum marker that we'll see. And so an antigen is something that attacks the body, right? And we'll show you here in a little bit. Hepatitis B complex has a surface antigen and a core antigen. So there's two layers of it that can effectively attack the body. And so the surface antigen is the first one we're going to identify. Then the first antibody to appear is the IgM. And that is, however, against the hepatitis B core antigen. So hepatitis B surface antigen is the first to appear. Shortly after that, we will get IgM antibodies. So antibodies to the hepatitis B core protein. LFTs can be elevated, and then after a while, we can get antibodies to the surface and surface molecule as well. All right, we're going to work on this here a little bit. So I added this in previously. I do not like changing slides when I first take over a course, especially when it's been working. But hepatitis B serology is just, people love to test on hepatitis B serology. And I remember going through PA school, I needed a little bit of help from a couple different charts and visual aids to kind of appreciate what's going on here. So instead of just throwing words at you, I added this slide. It's up on Canvas if you didn't happen to grab it yet. However, let's play with this a little bit here. I'm going to zoom in. I want to look at this part here. Trying to get to the top right here. Okay, we're just going to make all this. The top right-hand corner, this is kind of that schematic we saw earlier in the slideshow. You can see the green oval shapes, and that's representing the hepatitis B surface antigens. And you see these grayish pearly round circles in the middle. That's representing the hepatitis B core antigens. And then it's a DNA virus, not an RNA virus. So what ends up happening, if you look over on the top left here, when the body is introduced to the hepatitis B virus, the first thing that spikes is this hepatitis B surface antigen, right? It's replicating in the virus. So that's the first thing that kicks off. The body has to recognize that there is a new antigen at play, and it's got to go mount an immune response to it. So for some reason, the first thing that we see is an IgM to the hepatitis B core. So it's an antibody, hepatitis B core IgM. That peaks right after your surface antigen. While that is also happening, we're starting to get IgG of the hepatitis B core as well. So again, two there. And then slowly we'll end up with antibodies to hepatitis B surface antigen. So that's kind of the timing of what happens. And you can see these bars up there front that talk about when the symptoms are present and they're exposed, etc. So the way that you'll end up typically getting a lot of questions on tests, because again, people love to test on the serology associated with hepatitis B. Across the top here in this diagram, we have the different stages, right? We can have somebody who is an acute hepatitis B virus. We can have somebody who's chronic hepatitis B virus. Then we can have somebody who has cleared and recovered from hepatitis B. And we can have somebody who has been vaccinated for hepatitis B. And so if you kind of play down these rows and columns, you can start to see the serology reports that you'll get. So if you have an acute hepatitis B virus, we already know that we're going to get hepatitis B surface antigen first, so that'll be positive. We should get the IgM, which is that initial antibody against the core. And we can also get some core antibodies. They're kind of being produced at the same time. But typically, if IgM is present, we are in an acute stage, regardless of whether we have IgG or not. Okay. Let's go over to chronic. Let's say you have somebody who's not recovered from it. They have chronic hepatitis B. The big difference is that we are no longer going to see IgM in the blood. We're not going to see that acute responder. Now we will only see the surface antigen, and we will see the IgG, which is that more longer lasting antibody to it. So these two people are actively infected, acute and chronic. It's just whether or not they're in the acute stage or the chronic stage. It wasn't listed on the slide here, but we use 6 months as that timeline to separate somebody from an acute stage to a chronic stage. So if they have hepatitis B virus at play for longer than 6 months, they've turned over into the chronic stage. All right, now let's take a scenario where somebody has been exposed to hepatitis B. Their body has mounted an immune response, and they have responded to it. They actually have a couple of things here. They have an antibodies to the hepatitis B core and antibodies to the, to the surface. I'm sorry, that's the one that was the surface and the core, right? Because there's two layers at play, right? Surface and the core. That means the entire hepatitis B virus is exposed to the immune system mounted a response, and that was its response. When somebody gets the hepatitis B vaccine, we only introduce them to the surface. So if you get serology back that is only antibodies to the hepatitis B surface, or HBs, that's the only thing that's positive. That means that they have immunity, but it is from the vaccine and not a natural immunity. That's a lot going on right there. And you guys are smarter than me. I expect you probably picked that up significantly faster than I did, but it took my brain a little bit of time and some practice when I was in school, still does, to kind of lay all this out. So some practice with these serologies and how they're reported will go a long way, because you will inevitably, both on your upcoming test, but also in your GI course, because there's a liver section in your GI course, as well as PANTS, pantry, anything you're ever going to take, you're going to see hepatitis B serology. People just love to test off of it. Let's take a break. We'll come back at 11:02. We're going to repeat what we just said about the hepatitis B serology, and we're here to get, but we'll go on break, and I'll stick around and answer questions if there are. You guys. All right, let's kind of repeat what we just talked about. Hepatitis B. If there's some serology pulled, and there is a hepatitis B surface antibody only. Surface antibody only. What does that tell us? Surface antibody only tells us that somebody is immune from the vaccine, because the vaccine only gives us protection against the surface. But that's okay. That's all we need. If there is hepatitis B core IgM and hepatitis B surface antigen, what does that tell us? Surface antigen and core antibody IgM. What does that tell us? What stage are we in? Nope, the IgM is the initial response. Nope, the IgM is the initial antibody produced. So if it's IgM, it's acute. You have acute hepatitis. So hepatitis antibodies, core antibodies that are IgM and surface antigen together, that is an acute infection. Now let's say that we have core antibodies, but they're IgG along with the surface antigen. So IgG plus the surface antigen. What stage would that be in? Chronic, because it's still an infection. We still got surface antigen. That means it hasn't been killed off by the immune system, but it's now IgM. That means we are past the IgM stage and the body's only producing the IgG. So we are chronic infection. So it's an active infection still. It's just been lasting longer than how many months? How many months did we say was that line for the chronic versus acute? Six months. 6 months. Excellent. All right. What if we have positive core antibodies, IgG, and antibodies to the surface, right? Surface and core antibodies. But it is negative for the surface antigen and negative for the IgM. Where are we at in that? So we've got antibodies to the surface and core, but to the core specifically is IgG. It is negative for IgM and negative for surface antigens. That's a natural immunity. Correct. I recommend playing with those. There were things that I would do to kind of help get it straight in my mind. For example, if there is a surface antigen, do we have any type of protection or clearance or immunity at all? If there is a surface antigen present, do we have any type of clearance or immunity at all? We don't. If the surface antigen is present, it's an active infection. Now the question is just, is it acute or chronic? Well, acute is only going to have IgM. If it's IgM positive and surface antigen positive, it's an acute active infection. If it's antigen positive but IgM negative, well, then it's going to be chronic because it's only have the IgG. And then yes, it is still chronic and it's infectious in its chronic disease. It just means that the body has not mounted an immune response that has been able to clear it out. Practice with those guys. It's not just this class. Lots of classes, lots of tests love to test on the serology. And it's important. It's a worldwide thing, right? And it's very infective and it's very dangerous. So understanding that is probably good high value effort. All right, we'll move on now. We'll keep practicing it. We'll get you there. So this chronic disease, continued hepatitis B surface antigen and the IgG. That's when we get to chronic. We just practiced that. They're carriers of hepatitis B and they're chronic hepatitis. And diagnosing it, this line just simply says take everything to play, which is true. All right, two different forms of treatment, right? Acute versus chronic. If we have acute, we want to do a lot of supportive therapy. People still tend to get antivirals. And you can initiate hepatitis B immune globulin with the hepatitis B vaccine if you're within 7 days of the exposure, if you happen to know when the exposure happened. If you have chronic hepatitis B, medicines can almost, or I should say almost, can lead to viral eradication. And the whole goal is to replicate, to inhibit the replication. Treatment for chronic hepatitis B virus, tenofovir or entecavir with pegylated interferon. Pegylated interferon has a long shelf life, so it helps go faster. If you use those 1 and or 2, then second or third line could be adofovir or lamivudine. And the hepatitis B virus DNA is a great monitor. Hepatitis C, this one gets a lot of attention, and there's a lot of hepatitis C. Most of the time, it's IV drug users. They're the ones who, just by nature of their vice, if you will, tend to decrease their risk level, a little bit more willing to risk it for the substance they want in their system. So IV drug users are at a high risk for hepatitis C. If you'll look at the very two bottom sub-bullets here, organ transplant recipients and transfusions in the U.S. says after July 1992 is low risk. Before July 1992 is a little bit higher risk, and it's because of when hepatitis C first started being recognized as a condition, and that it was bloodborne, and that there was not a lot of good screening and protective measures for it. So classic kind of test questions go, hey, which of these is higher risk for hepatitis C? And it might be somebody who had an organ transplant or blood transfusion in the 70s or 80s, right? Well before a lot of the precautions that are currently being taken to prevent transmission of hepatitis C through those routes. Here's a map of kind of its prevalence. Sexual transmission of hepatitis, a little bit less frequent, very much related to IV drug users. And the acute disease can be pretty mild. This bullet was pretty impressive to me when I started looking at this. 50% of Hep C cases can be attributed to either veterans, prisoners, the uninsured, or IV drug users. All right, hepatitis C, if untreated, can definitely lead long-term to cirrhosis of the liver. Some factors that promote that: alcohol intake, of course. Alcohol is going to hurt the liver as well. HIV co-infection is really bad to go along with hepatitis C. Male gender or chronic hepatitis B co-infection are also really bad predictors of long-term stability. All right, so who do we test? And this is kind of, again, people, we kind of like talk about this information of who do we test for hepatitis C, but you can also think of it as who is at highest risk for hepatitis C. So you got your injected or IV drug users, anybody who received clotting factors or blood transfusions before a certain date, people who are on chronic hemodialysis, and then other evidence of liver disease. If we have those at play, it might be worth screening for hepatitis C. And then you have other people who may just simply be exposed to it from different situations, maybe medical workers, or maybe they had a needle stick or something. I think I mentioned to you, I do a little bit of work on the side at an inpatient psychiatric facility. One of the patient populations we get a lot of is IV drug users. And so hepatitis C virus is very common amongst that patient population. Common enough that it's recommended I get screened for it at least yearly. All right, the USPSTF recommends hepatitis C virus screenings for those individuals between 18 and 79 and baby boomers. It's a very common thing to have all baby boomers screened at least once in their life for hepatitis C. Lots of progression to chronic hepatitis if it's not cleared, especially if it gets into that cirrhotic stage or produces a situation where cancer is a little bit more easy to handle. All right, screening. We can do an EIA for hepatitis C, and we can confirm it with a PCR. LFTs won't tell us that it's hepatitis C causing the problem, but it can give us a sign of the liver function based on how the AST and the ALT, the bilirubin levels, etc. Some people even need to go as far as if they have a cirrhotic liver to get biopsy to see if we can stage what's going on or see if anything else is going on. Treatment in the acute stage, a lot of supportive therapy. Antivirals, get them started as soon as they can. And if you have an individual who's willing to avoid alcohol or hepatotoxic drugs, highly advised. Anything to take load off the liver from getting worse as I can. Not significantly different from the chronic stage. Still want to get the antivirals and tell them to please avoid anything that can damage the liver. That goes for us too, because there are definitely some medicines that we can prescribe that have hepatotoxic effects. In fact, whatever drug prescription resource you like, whether it's up to date or Hippocrates or maybe a handheld one, a lot of them will specifically have hepatic failure or have hepatic limiting dosage adjustments or recommendations for you to consider as well. Hep C is now considered curable, which is great. And there's a couple of medications that can help, and those are at the bottom of this page here. Epclusa and Mavorite are the brand names. Epclusa, suvosivir, and velpatasvir. Guys, I'm not going to try to pronounce those. If you guys got it, I'm happy for you. I sound like such an idiot when we try to say these. So let's kind of be familiar with them. If the drug reps show up, you can press them. I don't know why they got. But I like looking for the VIR. Right? The VIR tells me it's an antiviral. Antiviral and hepatitis C virus. All right, hepatitis D. There's something unique about hepatitis D, and that is that it cannot infect the body unless there is also hepatitis B. Hepatitis B or Bravo can present without hepatitis D. However, hepatitis D absolutely requires a co-infection with hepatitis B, Bravo. The reason is that the hepatitis D virus needs the surface antigen of the hepatitis B virus to help in its replication. So if you have somebody that's positive for hepatitis D, they are automatically also positive for hepatitis B, the not necessarily the other way around. And if you get a super infection with chronic hepatitis B and hepatitis D, a significantly higher risk of chronic liver disease, cancers, etc. Parental exposure, such as injecting drugs and mucosal contact, those are the two primary ways that people get exposed to hepatitis B. Here's a map kind of showing where it's typically found. If it happens, giving them the hepatitis B treatment and or immunization series can't help prevent it, because if they can help, I'm sorry, not if it happens, they want to prevent it. Because if they don't get hepatitis B, then they cannot get hepatitis D. And then it kind of talks about some therapies here. Hepatitis D, again, supportive therapy, and we got to treat the hepatitis B accordingly as well. All right, hepatitis G, aka GB virus, and that's the initials of the doctor that kind of first recognized that this was not an actual hepatitis. There's some information here about it. However, it is technically not a hepatitis virus, transmitted by blood, and a lot of co-infection with HIV and HCV. However, it is actually not inflamed the liver, so it is not technically a hepatitis. So there's kind of a gray area for that one. So I'll bring it to your attention just for that purposes, but I recommend kind of streamlining the information that we went over today. We have hepatitis A and E, fecal oral, relatively recoverable, a lot of supportive therapies. Hepatitis E had that really kind of unique caveat: if it ends up in a pregnant individual, much higher risk of mortality. Hepatitis B, very fast. Hepatitis B, a lot of serology at play there because it's a DNA virus, not an RNA virus. It has the core and the surface antigens, so we can get different antibodies at different times. Some practice with the different serology results likely be very value added. Hepatitis C, again, a virus, typically IV drug users, and there's some symptoms and medication indications there as well. And so with that, that is your hepatitis lecture. That is all for today. What questions do you guys have for me? You're more than welcome. Good luck on your test tomorrow, y'all. So in 2021, in 2020, we were doing almost all lectures virtually. And back then I had a really, really young son who would get on the microphone and wish you all good luck. I don't have a really, really, really young son. I mean, that may know that's a good thing. Zach, let's just go back to the page here. Zach had a question about hepatitis C treatments. Here it is. I'm not sure what you're asking me to repeat. Treatments are a lot of supportive therapies. Obviously, you want to prevent it from going into a chronic cirrhosis state. And then these two are some direct acting antivirals. Influenza and Mavord are the names we're familiar with because they're easier to say than the antiviral generic names. And if we can get those on board, typically hepatitis C responds pretty well. However, a lot of individuals can't necessarily afford them, unfortunately. So a lot of, especially the underprivileged population, which also tends to be our little higher risk ones for IV drug use, tend to be limited to get those medicines. So you tend to see them stay kind of chronic with that Hep C size. Then avoid alcohol and any medicines that are toxic to the liver and hit the liver. I don't know if that answered your question, Zach. Kind of hearing that again. If you have a more specific question, I'll do my best to answer it for you. Zach, absolutely. If we can get the individuals to avoid things that damage the liver independently, and there are certain medicines. I mean, Tylenol is kind of the flagship one that's processed out by the liver, and so like excessive Tylenol use can hurt the liver. Alcohol we know is processed by the liver. So if we can get the individual to stay away from things that we know will hurt the liver, right? Drugs, alcohol, etc. If we as the clinician can limit the things that we know can hurt the liver, certain medicines, etc., and we give them the antivirals, they stand a pretty good chance of seeing a good outcome from that. If the patient cannot do all of those for whatever reason, the more of those that they can do, it should decrease the risk of turning into chronic severe hepatitis that is very impactful to the body. And unfortunately, what happens is as this chronic hepatitis picture produces, it doesn't happen overnight. And the liver is a relatively decent sized organ. It just slowly becomes inflamed, and then it scars and becomes cirrhotic. It decreases its ability to do what it's supposed to do, which is metabolize the blood a lot, produce the clotting factors, as well as the production and the processing of the bilirubin, etc. And just as that continues to get worse and worse throughout time, now you're in an increased risk for what the liver is supposed to do, as well as an increased risk for cancer, cirrhosis, and then God forbid, encephalopathy. So our goal with a lot of the hepatitis treatments is to either one, cure it, and if you can't, then at least slow the progression down to offer the patient as long and as good of a life as possible by protecting the liver. The liver, I had a patient one time trying to explain to him all of this, and he was like, "Oh, I don't really care. I'll just get a liver transplant." And I was like, "My man, it's just not that easy." So even though we do hear about some transplants and stuff like that, usually people only get one liver in their lifetime. So our job is to preserve it as much as possible with a lot of counseling and prescription treatments, etc. Hopefully that helps a little bit. Did that kind of help a little bit, Zach? All right, that's the end of class. I hope you guys have a great lunch, great test day tomorrow. I'll hang out just for a little